Thanks, Warren, and thank you for the opportunity to talk today. It seems kind of early to talk about death and dying, doesn't it? But I think that's the point, right? It's never too early. So today I'm going to talk about just a breadth of research that we've done at ICES, looking at what happens when people die in Ontario. And in terms of disclosures, I don't have any just funding sources, quite a few of them just to support this research, but no ties to industry, no consulting fees. So just a quick outline of the presentation. I'm going to talk about what the issue is when it comes to end-of-life care in Ontario. And I'm going to talk about how acute care in Ontario is very acute care-centric right now, and hence costly. And I'm going to put forth one solution, which is not it's sort of a no-brainer, but it's to try to improve the reach of palliative care. And I'll show you some of the stats and some of the data on who is getting palliative care in Ontario and where's the gap and how can we reach that gap. I'll show you also evidence from our research about the effectiveness of palliative care, specifically in Ontario, but it can be generalizable to other populations and jurisdictions. And share with you some of the things that we're doing to try to improve the reach of palliative care in Ontario. And anytime, jump in, ask questions. This is meant to be interactive. So this is the first study that we published in this series of end-of-life care in Ontario. It was a really slow news day, so this made front page of National Post. Last month of life cost healthcare system $14,000 on average. That's our report that we published. And how do we look at that data? Well, we took a very simple approach. We took a retrospective cohort approach, and we looked at all people who died in Ontario over a 3-year period. So that came out 264,000 deaths, over 264,000 deaths, and that's all deaths in Ontario. So any deaths that you might have taken care of during these years, we captured that experience. And we look back from that death experience, 1 month prior to death, to look at what's happening, what kind of care is being provided to these decedents. So I'm not sure how many of you are familiar with ICES. It's not no longer called ICES. I don't know if people know. It's because of the bad connotations to something else. But anyone here, are people aware of ICES data? Anyone work with it? Okay, so a couple. So at ICES, what we've done for this specific project, but in a lot of studies, is look at the care that's provided at the individual level. So many of us here, probably maybe all of us, have an OHIP number, and each time you seek out services using your OHIP card, we capture that data. So if you see your physician, family physician bills, for that visit, we capture that. You go to the ER, we capture that. You get admitted, you receive home care through CCAC or the LIN, we capture that. Okay. So what we've done for this study is we looked at individual level healthcare use in the last 12 months of life across all health sectors that are available in ICES. And in acute care, that means hospital admissions, ICU visits, ER visits. In the outpatient setting, is physician claims, as mentioned, outpatient visits, drugs, labs, devices, ATP devices, and so on. Continued care, so we capture when or not person gets institutionalized, so enters a nursing home, enters CCCP, complex continued care bed like Briere or Bridgepoint or Baycrest, home care and rehab. So we looked at, the first question we looked at was, what made up the headline was, what was the cost in that last 12 months of life? And that was the total cost. Well, you saw the headline, it was $14,000 in the last month of life, but in the last 12 months of life, the average decedent across all decedents cost the healthcare system $53,000. And when we look at it by age, you can tell here on the y-axis is average cost in the last 12 months of life, and x-axis your age group. You can tell that the cost is highest in the middle age groups and lower, no surprise, in the lower end, in the older age groups. The lower age groups because a lot of people die suddenly, and the older age groups because actually they, people who are frail and die of that frail trajectory, we observe that they actually cost less. So when we added it up, the total annual cost came to $4.7 billion, which is a bit more than 10% of all government-funded healthcare for less than 1% of the population. So where's this cost being spent? Well, maybe not surprising to people in the room, but the majority of the cost is spent in acute care settings. So you can tell here, this is cost in millions, and we just tallied up the costs of all decedents, and 43% of all costs across all health sectors is spent in the inpatient or acute care setting. When we think about home care, most people obviously want to stay at home and potentially die at home if they have adequate supports. And when we look at home care, that home care support that's supposed to keep people at home, we spend only about 8% of the total cost in the last year of life on home care. Physician costs, which typically dominates, is a third of our healthcare budget often. In other times of the life course, it's only 10%. So it's very dominated by acute care inpatient costs. So end-of-life care is expensive and hospital-centric. So what does that curve look like as death approaches? So this is a curve. The top line here, I think that's gray, is total cost across health sectors. And the y-axis here is total cost in millions or billions. And on the axis here is months or days prior to death. And as we get closer and closer to death, you can see total cost is actually pretty stable. So it's fairly stable in the last year of life until you get about the 3 or 4 month period before death. And that's when it really skyrockets up. And when we broke it up by sector, you can see that it's the red line, acute care costs, that's really driving up total costs. So the cost in the community, so outpatient costs, physician home visits, CCAC, home care, none of that really is rising that much in the last year of life. It's all acute care costs and all in the last 3-4 months of life. I don't know if that's a surprise to anyone, but I think it's quite striking, right? And it's quite a balance, counterbalance to what we want care to look like when it comes to the end-of-life period. So I show you the stats for hospital-centric care. So are we unique? So this was a study published a couple of years ago in JAMA that looked at Canada in comparison to other countries, other developed countries, so Belgium, England, Germany, Netherlands, Norway, US. And the first question they asked is, out of these countries, which country had the highest proportion of people dying in hospital, right? So what proportion of people died the highest in hospital? Any guesses on which country ranked first and which country ranked last? First, who had the highest? Any guesses? Kelly, have you seen this data before? I think you have, right? So you can't keep it away. Anyone guesses? Yeah.
I would guess the country that has the highest in-hospital death is the one that has the lowest investments in home care. That would be Canada.
Yeah, so the answer was whoever spent the least in home care, Canada, might have the highest deaths. So, I mean, it's almost like a what's the word? Anyways, which country has the lowest? What do you think? Someone said Netherlands? Okay, Netherlands, yeah, Netherlands is one of the lowest. It's actually not Netherlands. I'm going to show you the stats here. So it's interesting. Canada's number 1. So, obviously, I'm trying to prove a point here. So Canada has the highest rate of hospital deaths among these countries. The middle countries, it's hard to kind of, judge which ones have the, highest rates. But you can see, a lot of people would guess actually the US would be the highest, right? Based on their, costly acute-centric system. But Netherlands came at second last, and it's the US that came actually dead last in terms of the proportion of people dying in hospital. And it might be a surprise to people, but in the US, I mean, it's a cost-driven system, obviously, and the Medicare system, the insurance system have figured out that most people want to be at home and actually costs cheaper to provide that care in the home. So what happens in the US is when you're dying, you identify that as dying and you have irreversible disease and terminal stages of life, you get provided a lot of care in the community. The flip side of that is, you don't qualify a lot of acute care, that you might if you were not dying, but that's what happens in the US. So how about in Ontario? Do we see large variations? We have sites all across Ontario, right? So do we see that variation across LINs? So yes, so when we look at the crude range of number of people or percentage of people who die in hospital, the range is from 45% to 60%. That's the crude range. And when we adjust it, the difference actually gets larger when we adjust for age, sex, chronic conditions, so on and so forth. And this is a bar graph. Y-axis, percentage of decedents who died in hospital, and you see the 14 LINs there. And you can tell that Northwest, Toronto Central has the highest rates at about 60%, and Champlain has the lowest rate at 45%. And we think that's partly because of the regionalized palliative care system, partly because of the regionalized palliative care system in Champlain. So quite a large difference, and it seems like it's not a large difference, what's 15%, but 15% across entire populations, right, entire LINs. It's actually quite a large number of people, and that's, again, up to a 50% higher risk when you adjust are dying in the hospital. So can some of that be prevented? Probably, right? So large variation across the world, large variation even within Ontario. So what can we do about it? Well, one of the answers obviously is to provide end-of-life care, palliative care in the community settings away from hospital-centric settings. So I'm going to show you a quick video, if it works, it's a video that the Ottawa system did on a study that we published about providing care in the community, okay, through physician home visits. So that was a video from one of my patient's wife, and he had pancreatic cancer, ended up dying in Maycourt in the community. And I think there was a couple lines there that to me really stood out. I think one of the lines that she mentioned was she didn't think there was a choice, right? That she had a choice that she could request or ask for care in the home. And I think in reality, later on in the video, she said something like, she thought she was, lucky that, her provider was able to provide that care in the home. And I think what I'm going to show you is that, really a lot of Ontarians don't have that choice. So this is the stats across Ontario of people who get palliative care. So on the left-hand side here, so again, we looked at all people who died, and we looked at in the last year of life, how many of them received palliative care in the last year of life. And on the left-hand side there, you can see that 52% of patients receive any palliative care from any setting, includes acute care, inpatient, CCAC, any setting in the last year of life, but only 20%, only 1 in 5 will receive that care in the home. So again, I'm a family physician, I provide palliative home care to my patients, and to me, it's definitely part of, I feel it's part of my job, to care for people from, from birth to death. But I think a large proportion of people, 4 in 5 of Ontarians never get a single home visit in the last year of life, and will never get a single palliative care destination of end of life through palliative home care through CCAC. Some patients are more likely, just like that patient there, to receive palliative care in the home, 2.5 times more likely. And it's actually a lot of people who die of frailty, of dementia, of organ failure. Those are the ones that really, go even really beyond or even lower that 20%. So who's providing this care in the last year of life? So, I think there's a misconception that it has to be a palliative care specialist. I think more and more, we're recognizing that, everyone has a business in palliative care and everyone has a role in delivering palliative care. So when we looked at, decedents, this is a larger cohort, this is more newer data. So now we had, it looks like, I think 5 years of data, 460,000 deaths. And we looked at in the last year of life, who received palliative care from a physician, and where was that, or who was that physician that delivered that care. And you can see the first branch there that 51% did not, low palliative care engagement means they did not get any palliative care from a physician in the last year of life. And among the 48.5% who receive palliative care from physicians, we broke it up into decedents who receive care strictly from specialists, strictly from generals, and palliative care generals could be, geriatricians, family physicians, GIM, any specialty. And that proportion of generals only care was 20%. Specialist only care was 12%, and consultation palliative care, where there was both the generals and the specialist palliative care billing in the last year of life, was 16%. So you can tell, one of the things that you can take out of this is that 50% of people do not get any palliative care billings in the last year of life, and some of that is under billing because physicians sometimes don't bill for palliative care billings. Excuse me, but you can see that when you tally up the consultation palliative care and specialist palliative care, that's the number of, or the proportion of people who get palliative care by specialists, and that adds up to less than a third. So for all the care that palliative care specialists deliver is less than a third of the Ontario population before they die. So that gap, can only be met, by generals. So I talked about home setting, but how about in the acute care setting? So I showed you that curve, right, of rising costs in the last year of life. And the comment that I always get is, well, isn't a lot of that cost in acute care because we're delivering palliative care in acute care settings, that we're actually delivering care in PCUs, palliative care units, that's quite appropriate? Well, when we look at the last year of life and we look at all hospitalizations, we ask, what percentage of those hospitalizations had any palliative care involvement? And you can tell here, the no palliative care involvement showed that out of all admissions, 66%, 2/3 of admissions in the last year of life before they died, had no palliative care destination. So no billing, nothing in the chart that said that this patient was end of life for palliative care, or that supportive care was provided by a nurse, a physician, spiritual care. So 66%. 4.7% had high palliative care involvement. So that's when palliative care was the most responsible diagnosis for that admission, and palliative care was MRP. In TOH, I don't think palliative care can be MRP, but that would be PCU beds. So, well, a lot of that would be PCU, acute care PCU beds, when their MRP and palliative care was the main reason why they're there. Median palliative care involvement, 8.8%, and that's when palliative care was most responsible diagnosis, or palliative care was the most responsible physician or provider, or there was a consult with palliative care specialist, so any consult where palliative care was involved. And 20% was when palliative care was mentioned somewhere in the chart. So a large proportion of hospital admissions, even, I'm not going to show you the curve as death approaches, even at death, and even as death approaches, the vast majority of admissions have no palliative care involvement. So when we look across all sectors, this is the rule that we try to coin, but so approximately 50% of decedents will get palliative care. 50% of palliative care is delivered late in the last 50 days of life. 50% of palliative care is initiated within 50 days of death, so quite late. And what we envision as community-based palliative care, again, only less than 5 or 1 in 5 receive physician home visits, and 1 in 5 receive a palliative care destination by home care, by CCEC or the LIN. So, I showed you that there's very few palliative care that's delivered in community settings. Does it really matter? Does it make a difference? So, this is a study, another study that we looked at the impact of physician home visits in the last year of life. And for people who didn't get any visit, the proportion of people who died in hospital was 57%. If you get one visit, at least one visit from any physician who's not a palliative care specialist, that percentage goes down to 40%, and if that physician was a palliative care specialist, that percentage goes down to 35%. Okay, so you can tell that some of hospital deaths is amenable to palliative care to deflect that death into the community setting. So that was crude. So how about the multivariate model? What if we adjust? So the outcome here is risk of dying in hospital. And that includes acute care, CCC, and rehab. And we adjust for age, sex, a whole host of factors, income, quintile year. ATG score is a measure of multimorbidity. We adjust it for the fact that you have to be at home to get a home visit, right? I mean, that's a confounding by indication sort of issue. And we adjust it for the fact if whether or not you're at home 1 week prior to death. And when we looked at the multivariate model, PAV home care, it still holds up. So people who get PAV home care through CCAC will have a 50% lower risk of dying in acute care settings. Again, only 20% of all decedents receive this care. And for physician home visits, it's similar, 50% lower risk when it's actually a generalist like myself providing that care, and 60% when it's a specialist providing that care, PAV care specialist providing that care. And again, only about 1 in 5 will receive that care of Ontarians who died in the last 5 years. So that's dying in hospital. How about, I think a lot of us, obviously, or a lot of people would say, well, maybe I don't mind dying in hospital. I want to stay away from, in hospital and when I'm actually dying. So we looked at the number of days in hospital in the last 90 days of life, and we asked, does it make a difference if you get that care in the home? So the Ontario average in the last 3 months of life is 16 days. So the average Ontarian spends just a little bit over 2 weeks in hospital in the last 3 months of life. And when we adjusted, when we had the same adjusted model, multivariate model, looking at the impact of physician home visits on number of days in hospital, you can tell here that the more visits you get, the less days in hospital that you'll spend. So even if you get 1 visit adjusting for all the same variables, you'll spend on average 3.5 less days in hospital. And if you get regular visits, 5+, you spend 1 week less in hospital in the last 3 months of life. And that was the story there. So it's almost like I always put this up, which color house do you live in, right? Like it's quite haphazard who gets physician home visit. It's quite haphazard who gets PAV care in the home. It depends on who's your family doctor. If you're admitted, it depends on who's admitting you, who's the GIM physician, did they think about, that whether or not you're dying or not? Did the hospital have a PAV care specialist team that's ready and available and not overburdened? Do you have, other allied, workers, nurses, PSWs who recognize, whether or not you're dying? All of that, in Ontario right now, at least, is quite haphazard on who gets that PAV care, unless you live in Champaign, right? You have a regional PAV care team, but no. But a lot, even within regions, I think it's still quite random, not random, but quite haphazard on who gets PAV care in a community setting. So what's the issue? How are we helping? Well, it's multifactorial, obviously. I think one of the reasons why we're not having systematic delivery of PAV care, especially in the community setting, is because we don't have measurement systems. We are starting to work at this, so we work quite closely with the Ontario PAV Care Network, the Ministry of Health, Health Quality Ontario, and we are building measurement indicators, right? So these are the big dot indicators. I think that a lot of the LHINs have signed on to, or all of them have signed on to. There's some resistance from different LHINs, but the big dot indicators that the LHINs have agreed on measuring and trying to improve are percentage of people dying in hospital. A lot of the data I showed you, percentage of people receiving palliative home care through CCAC or the LHIN, or physician home visit, and percentage decedents with 2+ ER visits in the last 2 weeks of life. And I think what you obviously can't improve what you don't measure. So I think with that measurement, I think we'll get hopefully we'll see some improvement at the system level. So part of the issue again also is what models of care work. So we have little evidence on what really works to prevent hospital deaths and what is effective at providing quality PAV care at the end of life. And so we work quite closely with our partners as well on that. I'm not going to go into any detail on that. The last issue that I want to talk about, and I'm going to sort of test drive a tool that we've built, is prognostication. So what proportion, like how many of you actually work at the bedside? Okay, so a few of you work in the bedside. And I think, for people who work at the bedside, I think a lot of us, at least myself included, we get uncomfortable sometimes with prognosticating when a person has, when a person, is in a terminal stage of illness, right? And I think, with the big data that we have, what we've done is we've taken advantage of that data and we've created a tool to help clinicians, and not only clinicians, but families, patients, caregivers, prognosticate how long they have to live if they're frail. And this tool that we've built, we've called it RESPECT. Doesn't really matter what it stands for, but it's a tool that helps patients, families, clinicians prognosticate how much time people have left to live. The outcome here in our tool is death or survival time. And the data that we use is home care data. Okay, so home care data, I don't know if people realize that. We have a richness in home care data that has information not only on who that patient is, what chronic conditions they have, but we have also information about their level of function, so their activities of daily living, their instrumental activities of daily living, their cognition, their symptoms. And so we use this data, over 1 million assessments, and we created a multivariate algorithm, cost proportional hazard model, to estimate survival, okay, based on 25 fairly simple questions that anyone can answer. So when we look across all the variables, this is how it shakes out. So here, I'm going to show you bar graphs, and the y-axis basically is hazard ratios, or the hazard, the risk, the increased risk that you have if you had these characteristics. Sorry, it's small here, but this is symptoms, okay? So you can tell that some symptoms like vomiting or decreased food intake, weight loss, has a decent hazard ratio, 1.2, so 20% roughly higher risk, 30% higher risk. And remember, this is the multivariate mall hazard ratio, so this is accounting for age, sex, and everything in the mall, right? So all the variables. And stage disease, so whether or not you've been told by a clinician that you might have less than 6 months to live, all right? So this is kind of like the surprise question, right? Did someone's, did the surprise question, would you be surprised if you had 6 months or less to live? Your patient had 6 months or less to live. And if it's no, your hazard ratio is really high, right, 3.4. But not complete, but you can see even apart from that clinical gestalt that we make, that clinical judgment that we make, there's other variables that help us prognosticate. So one of the things that are really, that's really predictive is ADLs and IADLs. So instrumental activities of daily living are things like, I'm gonna get this wrong, shopping, managing your finances, forget what else. The higher level executive function, right? Instrumental activities of daily living. ADLs are things like toileting, ambulating, getting up, walking around, dressing yourself. And you can tell that these are scores in the RAI, the Resident Assessment Instrument, and the higher your score, the higher your limitation. From completely independent, it's IDL and ADL1, and completely dependent is IDL6 and ADL6. The higher your hazard ratio, and it's quite large. When you imagine that this is accounting for age, sex, and everything else, right? So how about chronic conditions? So surprisingly to us, chronic conditions, when you adjust for everything else, including your level of function, it's not that predictive, right? So you can see here CHF, congestive heart failure on the right, decent hazard ratio, 1.27. But you can tell that other chronic conditions like dementia or coronary heart disease, Parkinson's, diabetes, stroke, none of that is really that predictive once you account for the patient's level of function, okay? The client's level of function. You can tell that multiple sclerosis, that's an artifact, but I'll talk about that later if people are interested. So we build our predictive model, and we looked at all Ontarians, and we validated our model, right? So we had a cohort, we built our predictive model, and we tried to validate on an external, so a different population, and we asked ourselves, is our model actually performing well or not? So what we did is we took on this validation cohort, we broke up this validation cohort into 20 different risk groups. So, if there's 100 people, we broke them up into 20 groups of 5s, for example, and we ranked them based on their predicted risk, and we compared their predicted risk to the actual deaths that we observe in those populations. So these X's are these quintiles, so 20 risk groups, and and again on the y-axis here is the predicted mortality, and this is your observed mortality. And what we found here is, well, if the X is on the diagonal line here, then you have perfect prediction, right? And so our prediction was fairly good, that of the groups that we split up into 20, we predicted their mortality, quite well compared to the actual deaths that we observed. Okay, so in the last 10 minutes, or 5 minutes, I'm gonna show you our tool, and then hopefully I can get some feedback from the group. So this is, you can try this yourself as well. I'm gonna open it up in a bit, but we're gonna go through a case vignette, and we'll see what sort of risk this person has compared to kind of what you think this person has before you look at the tool. So the case here is Mr. Johnson. He's 74 years old, retired electrician, and he has multimorbidity, unlike a lot of 70-year-olds. So coronary heart disease, congestive heart failure, and COPD. He is getting some home care from the LIN. So he has some difficulty with meal prep and housekeeping, some difficulty getting around the house and using the bathroom because of his COPD. And he's been on oxygen for a couple of hours. Okay, so, quite moderately advanced COPD. He just recently visited the ER and was hospitalized in the last 3 months for his COPD. And since discharge a couple of days ago, he's experienced some weight loss. His physician wouldn't be surprised if he died in the next 6 months because he's been hospitalized, he's using oxygen, quite potentially end stage of COPD. But he's actually has a quite positive outlook. He's looking forward to recovering and attending his weekly card game. So the question here, fairly typical patient, right? What's his prognosis? What's his life expectancy? Would you initiate palliative care, right? Would you initiate palliative care in the community setting? I don't know. What do people think? Like, would you think about palliative care in this sort of patient? It's not your typical patient, right? If it's a cancer patient, terminal pancreatic cancer, or terminal lung cancer, metastatic lung cancer, you might initiate palliative care. In this sort of patient with organ failure, has some level of frailty, it's sometimes hard to judge, right? It's hard to judge what their prognosis is, hard to judge whether or not you should start having that discussion. So we're gonna open up the tool here, and it's your laptop, right? Hopefully you have Chrome. So this works on Google Chrome. We're pilot testing this in Windsor, Essex right now through the compassionate communities. The first thing here is splash page. Do you want to know how long you have to live? We're going to begin here. There's a survey here because we're still pilot testing it, but I'm just going to close it off. So we've designed this not only for clinicians filling out for their patients, but also for patients themselves or family members filling it out for themselves. And depending on what you click, we change the language, right, to make it more clinically focused or less clinically oriented. So I'm going to say a patient. Okay, and there's a warning here that it's for patients or people who are frail, right, people receiving home care. And we're going to say, yes, we would like to continue. And we're going to start filling out information for Mr. Johnson. So Mr. Johnson is male. He's 74 years old. And you can tell here on the right-hand side, as you fill in information about your patient or yourself or your loved ones, we show you what your risk is, okay? Centering on all the other all the other questions. So not knowing anything else about you, only that you're receiving home care and that you're male and 74. We have this dial here to look at your level of frailty. That was a request from our compassion community partner. But here we have the typical survival that clinicians like to look at, right? So 5-year survival, 52%. 1-year survival, 93%. 3 months, 99%. A lot of patients, I think, struggle or, it's not very intuitive to a lot of patients, 5-year survival. So we look at life expectancy. So what is your life expectancy for people with the same responses as you? Here, the patient still has more than 5 years. And here's the IQR, interquartile range. 25% died within 2.9 years. 25% of people survive past 7.7 years. And then we have on the right-hand side here the case diagram. So out of 100 people with the same responses, how many would have survived in the next year. Okay, so here you can see 93 survived, 7 people passed away. So Mr. Johnson, we're going to fill in more information. I'm going to put it on life expectancy here. So I think we said he was an electrician, so he completed technical or trade school. We said he had CHF. You can see the life expectancy keeps on, will change. He has coronary heart disease. What did we say? COPD. He has COPD. And this is based on that 1 million assessment. As you enter more information, this is the experience of Ontarians. So what we did is we put people into this multivariate model, and then we spit it back out again to say what is common experience for patients with the same answers. So we said yes, patients might have a prognosis of less than 6 months, and you can tell no surprise there that the life expectancy goes down quite a bit, 2.1 years. We said that he had issues with, I think, meal prep and housekeeping. And we'll say that he has some, but not great, difficulty. And you can tell there that life expectancy changes again. We said that he has trouble getting around the house, using the toilet. And we'll say that he needs limited assistance. And you can tell again, life expectancy changes. Now it's 17 months. 3 months survival, 84%, 5 years survival, 14%. Okay, so you can see how the risk changes as you enter in more questions. So has his ability to carry out these ADLs gotten worse? We're going to say no, it's been fairly stable. If we say yes, obviously it'll go down quite considerably, but we'll say no. Has your patient's capacity to make decisions, so this cognition, change over the last 90 days? We'll say no. Has he experienced some weight loss? Well, we'll say yes, just 5% maybe. And we'll say he hasn't experienced any other symptoms. But we'll say that he is on oxygen. And we said that he's on it for a couple hours, so it's scheduled, he's getting it. And as we click that, you see his life expectancy goes down to 11 months. He's been hospitalized recently in the last 3 months, we talked about that. And he visited the ER also in the last 3 months. So you can see for the same person with those answers, his median life expectancy is 9 months. So 25% of people with the same answers will have died within 11 weeks, okay, less than 3 months. 25% of people survive 2.3 years, okay? You look at the 5-year survival, so compare this to the worst cancers, right? Pancreatic cancer is very similar actually to pancreatic cancer. Percentage of people surviving 3 months, 1 year, 5 years, right? 9% surviving 5 years. Out of 100 people, 55 will die in 1 year, 45 will survive. And so, I think it gives people an idea of, survival that, otherwise would be, I think, fairly difficult. Yeah, question, yeah.
I like your sensitivity results. I like sensitivity results, the lowest expected, highest expected. But if I were a patient, I would want that to be a big number on the interface.
Yeah.
That's going to get lost, and that's going to send the wrong message to patients. So the time you can define what patient is in the next 9 months.
Yeah.
So really patient-centered, people be the wrong message at all. So that's one point. My question is, when should we do this? So when I take care of patients as an inpatient, I say, yeah, I can expect them to be dead in 6 months, and I see 3 months later, now they look great, and I say no to that question. So it fluctuates, that information fluctuates depending on the setting.
Yeah, great question. And we do have obviously different tools for different settings, right? So this is a tool primarily designed for the community setting. So I agree, like in the hospital setting, they're unstable. Should we use other tools? I would say we can use a combination of tools, right? So we have things like Homer. I don't know if you heard of Homer. A Homer score is something that Carl Funwell Raven and others have created, and it's being tested actually at TOH where, based on all the clinical characteristics that during their hospitalization, it'll spit up, a risk for death in the hospital acute care setting, right? And that's been validated in the acute care setting. Homer doesn't have ADLs, IDLs. Can we combine, Homer with something like Respect? I think so. That's our next work plan. And for this tool specifically, it's been designed for people receiving community-based home care, so people who are more frail, okay? So people who are regularly needing that care in their home. So that's the patient, that we are targeting here. And I agree, so we're pilot testing this because we're not sure what exactly patients want and what's readable and what's digestible for them, right? And you're right. So we thought about doing things like a slider, of these are the bounds, right? So not just the number. We get mixed results, and it's difficult because there's a whole science of this, right? And we have a grant actually looking at the science of risk communication, right? But you're right. The IQR, these are the bounds, 25%, 25 and 75%. I think it's very important to give people that uncertainty. Yeah. Any other questions? I think, well, we have 10 minutes, so I think that was all for the presentation.